Right, Dr. Brock Rondeau. Sorry, I just wanted to clear that. Brock and I have been friends for an awfully long time, and Brock is a highly respected speaker in this field and a dentist with over 30 years of experience just treating patients with orthodontics, TMJ, and sleep apnea issues. He's an extremely well sought after speaker, author, and educator who's lectured throughout the world. So we're very happy to have him here with us tonight. And I'd like to take this opportunity to welcome all of you and to give the floor to Brock. So Brock, we look forward to hearing what you have to say tonight. So thank you.
Thanks, Bill. Thanks, Bill. Well, I've been with you for 30 years, partner, and you've been a great help to me, for sure. I can remember starting out, you were helping me design appliances, and you end up doing that for most of the people that take my courses, and also tracing cephs and helping us analyze the cephs. And I really think you're the guy that got me into sleep. You told me all about sleep dentistry and for years, and I didn't do it for years. So finally I said, you know what, I got to do it. And now I think I love my practice because it's sleep, TMD, and ortho. So tonight I got 3 things I want to show you. I want to show you an anterior sagittal. I want to show you the class 3 motion appliance and the tandem appliance. And those 3 appliances are great for class 3s. So I guess we got to figure out Lee to get me going here. Where's that Lee? Good old Lee. We need Lee, but I got to figure out how to get this moving. Okay, here she comes. My right hand is here. And we're going to go. I see Bill. I don't see me. Hopefully I'll see me shortly. I think it's getting close to me. Okay. So Bill, I had a patient. Go ahead.
I was just going to say, I've got your screen showing now on my screen, Brock.
Right. Okay. So I had a dentist come to my office today, a female dentist who took my TMD course. And she was telling me a story that she sent a prescription to her local lab, not you, for the Ferrari appliance. And the lab made it wrong because the lab didn't know how to make it. And now she wants her money back because they made it wrong, and they won't give it to her because they made it. And so I told her, you have to deal with Bill Van Evans. He's the guy you got to deal with. You won't have any problem because you and I have fabricated appliances over the years, and we've made many changes. And so even someone who took our course 5 years ago, it's a different appliance now. Anyway, so Bill's been a big help, and he will be the biggest help of anyone after you finish my course. But let's show you a couple of cases. There's Bill right now. Look at him. His hair is longer. My God, Bill, look at your hair. You know, you look like a movie star, you know? Anyway, that's good. Okay, so let's talk about class 3s. Most dentists are afraid of class 3s, okay? And I agree. There's certain class 3s you're to stay away from. Like a class 3 skeletal open bite, vertical grower, ignore, get out of your office. Any class 3 with a prognathic mandible, get out of your office. But you're gonna look at the guy's picture. See, his upper jaw is deficient. See, the upper lip is short. He needs to have a facial development. This guy, the same thing. It's class 3, but the problem is the maxilla. So if the problem is the maxilla, we have appliances that will fix that. And if we fix it, some of these kids will be avoiding orthodontic surgery. Now there's a patient with a prognathic mandible. That would be prognathic mandible, refer. Definitely get some orthodontists you can work with and send the difficult case to them. That's why they took the specialty. So here's what I want to show you tonight. For mild class 3s, not too bad, you're going to use an anterior sagittal where there's a dental problem, because anterior sagittals are for dental problem. They're for moving the front teeth forward. For a moderate case, which is still dental, you need the carrier class 3 motion appliance. For severe cases, skeletal problems, you need the tandem. That's it. You can remember those 3 things, those 3 appliances, and when to use them, I'm going to show you all tonight. You'll avoid orthodontic surgery for the kids. So that's phenomenal. Never had a mother come in with a child that I recommended early orthodontic treatment for class 3 that ever said, I don't want to start. Look at this case. So here's a case. This patient came from Toronto, actually, because look at the recession on those two lower incisors because of the bite, the anterior cross bite. So, I mean, you don't want that to happen. All we have to do is fix that before that crossbite causes the recession. Look at this little girl here. This is one of my favorite patients. She's 4 years old. And she has difficulty chewing. She's having difficulty eating, and she's got speech problems. Look at her bite. Look at the anterior crossbite. There's no room in her mouth for her to chew or to talk. Her tongue is so upset that she's got to have speech pathologist. And there's the bite. She's got a deep overbite of 4 and an overjet of -2. What are you going to do with her? I can guarantee you, if nothing is done for her, she'll end up in somebody's office and be getting orthodontic surgery when she's 17. We can fix her right away. Well, you show what I did. So speech problem, being treated by a speech pathologist, difficult eating, difficult to chew, but there's no room in her mouth for anything. So we want to fix that. It's very simple. All you do is composite buildups on the lower primary molars. How much do you open? Maybe 2 millimeters. That's it. That's it. Just build those teeth up. And you know what's neat? The Mando rotates down and back. So you had a class 3 with an anterior, remember, -2 overjet, and now it's end to end just by opening the vertical. That's your key. Your key for class 3s is to open the vertical. Okay. So a very easy case. Okay. Remember, she's only 4 years old, almost 5. So all we had to do is put 4 buildups, and I charge $150 a tooth. So that's $600 to build up 4 teeth, and that's all you have to do for now. We're going to wait till the permanent teeth erupt, and then we'll see how they come in to see if we need further treatment. Okay, so once again, so easy. Build up 4 teeth. That's it. There's the composite buildups. There's the mother with the daughter, and look at the class 3. Look at that lower jaw, how far forward it is. I mean, these mothers are really worried about these kids. They want something done. Now, what we're doing is we're creating enough room for the eruption of the upper and lower incisors, because the way she was, there was no room for those teeth to erupt. I don't know what would have happened. And notice on the photo on the left, how we did buildups on the D and the E, the 2 primary molars, and the first permanent molar passively erupts to the same occlusal plane. We're establishing a new occlusal plane for this patient. Okay. So now we've just allowed adequate space for the eruption of the permanent lateral and central incisors. And when they erupted end to end. Now remember, she was in crossbite when we started. With the buildups, we put her end to end. But when those teeth come in, now we need Bill. We need Bill to help get those upper anterior teeth forward. So it's extremely important to remember, you cannot use an anterior sagittal if the upper incisors are flared, because you'll make them worse. But if they're vertical or lingual, it's a perfect patient, perfect design, and very easy for the patient to wear. There she is with a 3-screw anterior sagittal. You got double Adams clasp on the second primary molar and the first permanent molar. You got a midline screw, and you got 2 side screws. And the cut is distal to the lateral, so you can see those pieces. So here's how it kind of works. This is a different design. This is just 1 screw pushing all 4 teeth forward, because the patient wasn't constricted. And you just turn that. Now here's the case without buildups. We do occlusal pads on the appliance, but I prefer the buildups to the occlusal pads because they're on all the time. And now we just move those front teeth forward. You're moving the bone and the teeth forward. Okay. So now Bill's got the anterior sagittal in there. Sometimes I wait until the laterals erupt. But in this case, I guess I just decided to move the centrals out of crossbite because I didn't want them any traumatic occlusion. So we really turned these screws a lot. I mean, we opened that midline screw 3, the side screws almost 8. And I can tell you, I mean, she looks pretty good. So now it's working on the centrals and the laterals. And you can see with the midline screw and moving those 4 anteriors forward, we've got a much different size arch. I mean, now we're getting close to having room for all the teeth, which is the name of the game. And look at the lip. Look how the difference in the 2 lips. So Can you see the lips on the patient on the right? Bill, can you see that? Because I see me over there and I can't see that patient on the
No,
right.
no,
Can you see?
we've got, yes, I've got thin upper lip on the left and full upper lip on the right side of the screen in profile.
Okay, perfect. Okay, because it's covered up a little bit with me. Anyway, look at the difference. Okay, so the end-to-end bite, we push the 4 anteriors forward and you got the crossbite eliminated. And pretty easy. Remember, all I did to go from the left to the right was 4 buildups, let the teeth erupt, and put in an anterior sagittal and move the 4 incisors forward. I mean, look at the difference in that patient. I mean, tremendous difference. I got to tell you though, when you turn those side screws 7 millimeters, you don't push the anteriors forward 7 millimeters. It's probably about half because some of it goes to the back. But look at the difference. I mean, the patient on the left is a class 3 skeletal with a mandible in front of the maxilla. The patient on the right is a class 1 with a maxilla and the mandible lined up. I mean, huge difference. All it was an appliance. So Bill, what's that appliance cost? That anterior sagittal?
About $150.
Okay, well, let's see if I made a profit. We'll check that out in a minute. So the treatment results are correct the anterior crossbite as early as possible, increase the posterior vertical dimension to make more room for the tongue and the airway and everything, eliminate the speech problems. The speech pathologist was dismissed. No problems chewing anymore, no problems eating, and the muscles are close to the resting length. If you're over close vertically, the masseter and the temporalis muscles are really sore, and now they're not. So there it is. I mean, look at the anterior crossbite. Look at the difference. I mean, just so easy. All I did was 4 buildups and Bill's appliance, the anterior sagittal, and got a fantastic result. So the crossbite's correct. Now all we do is wait till the permanent teeth erupt. Remember, with those 3 screws in that appliance, we made lots of room. It went forward and it went sideways, and we created lots of room for the teeth. So look, the teeth are going to come in. There's room for all the permanent teeth because we use that appliance. And then we put braces on for a short period of time. So this, of course, not about braces, just about functional appliances, but the braces were probably on for 12 months just to line those teeth up. And that's the finished result. But the hard work was done with that anterior sagittal. Then once the teeth are then, we put a lingual bond retainer from cuspid to cuspid attached to every single tooth so they won't move. And there's the lower arch. So big change, but really 80% of the work was done with a functional appliance and the buildups, 80%. I mean, she looks pretty good. Nice case. There she is. And you can see the slide on the left is a thin maxillary lip. And on the right, she's got full maxillary lip. And of course, women like to put on lipstick. And they have a thin lip, they can't put lipstick on. So she looks much better. And there she is smiling away. And mother's pretty happy. I can tell you now, happy patient, no surgery. No, not even close to surgery because we were able to move the bone and the teeth forward with the anterior sagittal. Bill makes sure that he makes the appliance so the acrylic is down near the gingival margin. So you're pushing on that part of the tooth and not at the incisal edge where you're going to flare the teeth. Okay, so I didn't put down what I charged for that patient, probably $6,500. So probably $2,500 for the buildups and the anterior sagittal. And Bill says he charged $125, so I made a profit. So that's good. And the mother will pay it every time. If you just tell her, I can hopefully avoid surgery, you're okay. Now, I strongly believe in training your staff. So I give them tests from now once in a while. And so here are those girls writing a test, okay? And they got 95%. She got 95%. She got 95%. And they're showing off their exams. And then, of course, I give them each a bottle of wine. So we really, and that's in our courses, we train the staff too. And we're coming up with a staff program online soon. So just let you know that. But you have to reward your staff and you have to give them tests to train them. So The indications for that case was, no, these are the indications for the anterior sagittal. Okay, pay attention to this. Slight anterior crossbite. The patient can bite end to end. Okay, remember the anterior is in front of the posterior. The lowers are in front of the uppers, so they have to be able to bite end to end. That's very important. They have vertical or lingually inclined incisors. They have a deficient maxilla, and preferably in the deciduous dentition. These appliances are great for kids, and they'll wear them. They'll wear them. A lot of people say, oh, they can't wear. So Bill and I also know how to do fixed sagittals, but we're not showing those here. You don't want to put a fixed sagittal in a child when the teeth are not completely developed. You want to use a removable anterior sagittal and turn the screws twice a week. Real easy. Okay, let's show you another one. He's age 8, anterior crossbite. There he is. When are you going to fix it? When are you going to fix that? Look at the gingival margins, uneven. That's traumatic occlusion on the incisor, which is causing the uneven gingival margins. And he could be causing damage to those teeth. Anterior crossbite. So what do we have to do? We have to open the bite. And the easiest way to open the bite, you can either have Bill put occlusal pads on the appliance, or you can do buildups. Because the patient is going to have it in all the time, or not have the appliance in all the time, he takes it out for sports. He takes it out to eat sometimes. He takes it out to clean it. I would rather, when I started with Bill 35 years ago, we didn't know about composite buildups. All the appliances had the occlusal pads, but now I prefer the buildups if there's enough teeth. If there's not enough teeth, you don't have the lower primary molars, you got to use occlusal pads. You got to open the bite. Well, this is interesting. This is all you need a form like this to figure out what you're going to do at the first appointment. And usually my hygienist will fill this out. Okay, so he had the tonsil and adenoids removed. That stopped his apneic events. He's got an anterior crossbite. It also got rid of his sleep apnea and no asthma, got rid of his asthma too. So in my course, we talk about the importance of airways and breathing. And I'm not talking about that tonight, but anytime you develop the upper arch or make the upper arch farther forward or farther back, you're making it bigger, you're making more room for the tongue and opening up the airway. So the effects of the airway, when you take out the enlarged tonsils, you reduce the size of the pharyngeal airway. Tonsils reduce the size of the pharyngeal airway, so you want to get them out and open up the airway. Also, what's really interesting is if you've got large tonsils, you'll find the patient will brux more. And mothers are always coming in with the deciduous teeth all worn down and wondering what to do and hearing the guy brux all night. Just look at the tonsils, get those tonsils out. Okay, so there are the photos we take of every patient every time when they first come in. That's the initial records. And that's a TMJ health questionnaire form, which we teach in our course that you should do to evaluate the temporomandibular joint of all your patients, not just your ortho patients. He's having pain in the left ear and ring in his ears and bruxism. Okay, and there's the perio. You got to do the perio exam. Okay, so got an anterior crossbite. I mean, this is easy, right? All you're going to do is put buildups on there and move that upper right central incisor forward, period. Okay, so that's what we did. He wanted blue. He wanted blue bisfills. He didn't want white. He wanted blue. He wanted something different. So we offered him blue and he got blue. Okay, so there's the blue bisfill composites on the primary molars. The first permanent molars will passively erupt right behind them. So make sure there's no composite covering that lower first permanent molar to let it come up. He likes the Montreal Canadiens. Okay, this is a bad one to show with the Maple Leafs playing in the playoffs this year. You know, but I was born in Montreal, so it's funny. I came here not liking the Leafs at all. I was totally in the Canadiens. I still prefer the Canadiens to the Leafs, but I'm not unhappy with the Leafs anymore. I like the Blue Jays. I like the Leafs. I mean, when you're here for 50 years, I've been here for 50 years, you start to like the Leafs. So I wish them well. And so there's the appliance. So it's got, remember the cut is always distal to lateral. And you can see on the upper right-hand part of that appliance, you don't want the upper central and lateral to go forward. You want it to go against the one that's behind. So I have to grind that off a bit. So you have to do a little bit of adjusting in these appliances. But you got the 2 screws in the back, no midline screw here. And we're just going to move those front teeth forward. And there you can see it opened up nicely. And it's very, very popular, and it's very comfortable. People are always telling me, well, I don't think people will wear removable appliances. Well, Bill, you make thousands of them, and especially for younger children. Like it's the way to go. It's very comfortable. There's no plastic between the teeth, right, Bill? I mean, you make lots of those. And go ahead.
Well, we do. If these appliances, didn't work, we wouldn't have people keep asking us to make them and pay us to do it. So they're very, very successful appliances for patient care.
Yeah. No, and if you have trouble with the design, just ask Bill, what kind of class do I use? What teeth do you think I should put the class on? Because there's ball class, there's Adams class, there's C class, there's all kinds of different class. And I mean, I just phoned you recently and asked you for your ideas on clasping a patient for a snoring appliance, and you're missing a lot of teeth. So I said, what's your ideas on this? And you gave it to me. Okay, so there's the appliance. So you can see there's a lateral incisor behind that primary lateral on the upper. And we're just going to turn the screws, and we're going to move those teeth forward. I mean, 3 months, no more crossbite. And look at 3 months, just by turning those screws, right? They turn the screws twice a week. Okay, each turn is 1/4 millimeter. They open 2 millimeters a month. And that's fixed in 2 months, in 3 months. And look at the gingival margins. Isn't the mother kind of impressed now when she sees that? She says, wow, look at those front teeth. They're all nice and straight. And the other one's coming straighter too, the one that was behind. And they're pretty happy and very easy, just one appliance. One appliance and 4 buildups again. So don't forget the buildups. If you got a deep overbite, do the buildups. You'll make the class 3 better. Remember, in the last case, I turned a class 3 into a class 1 by building up the primary molars. That was it. That's all I did. So when you expand the maxilla, the roof of the mouth is the floor of the nose, opens the nasal airway and increases nasal breathing. And I talk a lot in session 3 of our course about the importance of airway and breathing. It's unbelievable how important it is to breathe through your nose and not your mouth. Anyway, there he is. He's happy. He's got a crossbite in the left and his crossbite's fixed on the right. He loves his Canadians. And again, there it is. And now all we're doing is waiting for the permanent teeth to erupt. I mean, but fix that problem, because his mandible is locked in a position, could cause TMJ problems later on, and just fix it as soon as you can. Get those appliances in and trust that those children will wear it. And the fee is around $2,500, but the record's $500, the same as the first case. Okay, I mean, $2,500, record's $500. You see the patient about every 2 months, and they're basically doing all the work themselves. They're turning the screws. And we have the mothers check them to make sure they're turning it right. Bill makes sure he puts arrows on the appliances to show what direction to pull them on. And it's fantastic. So there he is. Anterior crossbite, crossbite corrected. Looks pretty happy. 3 months. Not bad. And then we put brace on for 12 months. But most of the work was done with the functional appliance. So you have to charge adequately for that. You can't charge $1,000 for that. If you're doing 80% of the work and the average fee is around $6,500, you got to charge more. And I know some orthodontists are charging $3,500 and $4,000 for phase 1. Friends of mine. Luckily for us, as general dentists, there's a number of orthodontists who still are not treating early treatment for children. They still prefer to treat teenagers. And lucky for us, remember, all these patients are in your practice, right? 70% of the children in your practice have a malocclusion, and they want you to treat them. They don't want to go anywhere else. They don't want to go to a stranger. They want to go to you. And because they figure your fees are less, which they probably are a little bit, and also they are comfortable with you and your staff. They don't want to go anywhere else. So, and they always come back for phase 2 for braces if they need them. So there's an appliance that Bill makes now, slightly different anterior part, but it's a clear labial bow, which goes on the teeth And then usually on the lingual, you can see it there. There's a lingual bond retainer on the lingual from cuspid to cuspid. And also in the lower, you can see a lingual bond retainer. So you have to maintain those cases. You don't want the teeth to move. And so there it is, nice clear retainer, much better than those old Holly retainers we used to use 20, 30 years ago. And, you know, a nice case, easy case. So it went from there to there. We started at age 8 and he finished at 12, but he didn't come every month. We just did the buildups, moved the tooth out of crossbite, waited till the permanent teeth came in, and then put the brace on for 12 months. So again, it was $2,500 for 6 months for phase 1 with the anterior sagittal, $4,000 for 12 months with the straight wire. That's $6,500, and the records are always extra $500. So it's if you had 100 of those cases in your practice, you'd be pretty happy. And you got lots. Your practice is full of those cases. Okay, and I like the fact that the margins were uneven and they were fixed. And the teeth were crooked and they're straight. Now, here are the advantages of phase 1 treatment, okay? Number 1, you develop the maxilla so you don't have to do extractions, okay? You also correct the anterior crossbite. Now, a functional class 3 could become a skeletal class 3 if it's not fixed. And so you want to fix it. A functional class 3 means you start to bite and your teeth touch and then your jaw shifts forward into a class 3, into an anterior crossbite. You've seen me increase the support for the upper lip, prevent recession of lower incisors, and eliminate the need for surgery. Those are all good. There's Lee. So if you have any questions, call Lee at rondeauseminars.com, and she's on the phone all the time. She even takes her phone home on weekends. And she's talking all the time to dentists about things, how to help them with their practice. There's a nice shot of Hawaii. So again, remember, for mild cases, when it's mainly teeth involved and the upper incisors are very vertical and the patient can bite end to end, you want to go with an anterior sagittal. I showed you 2 cases. Very, very simple, okay? Every one of you can do that. All you have to do is do the buildups, get the appliance from Bill and turn the screws, or to have the patient turn the screws twice a week. I mean, that's not difficult. And it's a tremendous benefit to patients. And you're going to, as I say, you saw it. I mean, it was really easy. So for a moderate class 3, okay, I want you to think about the carrier class 3 motion appliance. You could also use an anterior sagittal too, though. But this is something which is brand new, and I've been using it for maybe 3 or 4 years, and I quite like it. But again, it's for a dental problem, not a skeletal problem. So you're just off. You can go end to end, and you don't. When you try to bite down, you go end to end before you shift forward. Okay, so it's a dental problem. Okay, and a severe problem, you're going to use the tandem appliance, which I'm going to show you next. I'm going to show you the carrier first, and then the tandem. Okay, so the indication for the carrier class 3 motion appliance it's a dental problem. The patient can bite end to end. If the patient's got a skeletal problem, they cannot bite end to end. The mandible is in front of the maxilla, and you got an anterior crossbite, and it's permanent. You can't go end to end. So say you got a slight anterior crossbite, you can bite end to end. Again, you got a deficient maxilla, and I prefer in permanent dentition. So the anterior sagittal for sure is to be used routinely in mixed dentition. And this one is one that can be used in permanent dentition. And the profile has to be pretty straight. Remember, not a prognathic profile. Prognathic profile, those are serious cases, and you got to think about referring those to the specialist. Okay. So here she is at age 12 with prominent upper cuspids and a deficient maxilla. So remember, you're going to treat deficient maxillas, not prognathic mandibles. Keep that really in mind and make a note of that. You don't want to treat prognathic mandibles. You're treating, she's got a retrognathic maxilla and a fairly straight profile. She just needs that maxilla developed. So there she is. She comes in and she's got a class 3 molar, class 3 cuspid, upper incisors extremely vertical, And you can tell a class 3 skeletal problem because they've got lingually inclined incisors. So this is kind of in between skeletal and dental. Okay, this is a pretty severe case. Okay, but it's not bad enough for a tandem, but you could use a tandem in this case. I'll show you. Okay, so she's 12 years old. Now here's the problem. When you're 12 years old, girls grow to age 15. So her mandible will grow more than the maxilla in 3 more years. So what you have to do is try to restrict the growth of the mandible, keep the deep overbite, which holds the mandible back. So very important. If you have a deep overbite in a class 1 or class 2, you want to fix it. But a deep overbite in a class 3 on a 12-year-old girl, you want to keep the deep overbite to hold the mandible back. Okay, that's something you got to think about. So lingually inclined incisors, almost all those cases have problems. All those cases are class 3s. Okay, so again, class 3 cuspid, class 3 molar. Same thing over there. Very vertical upper incisors and lingually inclined lower incisors. Very common with class 3s. So there's the appliance. It's kind of neat, developed by a friend of mine in Spain, Dr. Carrier, and it's a bar in the lower. So have a look. The bar goes from the lower cuspid to the lower molar. Okay, goes in the lower, and then you put a bracket on the upper second molar, and there's an S6 retainer on the upper arch, so the teeth won't flare too much. And you put a class 3 elastic on, and you get the elastics from the company that sells these. So Serum Ortho in Canada sells these, and they work quite nicely. So again, remember the bar goes from the cuspid to the molar, and it's the mesial 1/3 of the cuspid. Okay, it's not the middle of the cuspid, it's the mesial 1/3 of the cuspid, and to the middle of the first molar. And then you bracket the upper first molar or second first molar. In this case, they bracket the upper second molar, so the elastic pull would be stronger. Okay, and then an S6 retainer in the upper. Okay, there's the patient, open wide. Well, that's a model, of course, but that's what it looks like when they open up. And the elastics are very important. I'll show you those in a minute. So in this case, the cuspid was badly rotated. So we couldn't put the Carrier motion appliance on the cuspid. We had to put on the first bicuspid. And they call that a shorty. Okay, so when it goes to the bicuspid and not the cuspid, it's called a shorty. But we couldn't put it on that cuspid because it was badly rotated. The tooth has to be straight. Okay, so it's called a Carrier class 3 motion appliance. Okay, so you can see when you put that on, the elastics are pulling the lower bicuspids and molar back, right? You're starting to get a space distal to the cuspid. So that's when it goes on. No space there. Then they put the shorty on and the elastic, and there's the S6 retainer in the upper. And remember, you've got the bracket on the first molar in this case. So there should be some elastic showing up soon here. There's some elastics. Okay. So it's called a Force 1 elastic. You get those from Serum Ortho, who sells these Carrier motion appliances. So you have to use a Force 1 elastic on both sides all the time. And that will move the whole segment on the lower back. It'll move the molars and the bicuspids back. And then you'll have room to straighten out that cuspid that's rotated in the front. So it distalizes the lower arch, but also that elastic sometimes moves the upper forward too. So you're distalizing the lower part, but you're moving the whole upper maxilla forward a bit. So you'll see in a minute. That's what happened in 2 months. So you can see we've created a 2 millimeter overjet in 2 months. And it's a very good appliance for teenagers because they just wear a bar and an Essex retainer in the upper and force one elastic. They would take it off to eat, take the elastics off to eat. So there's the overjet, 2 months. And look at the space that we've created. So you got 2 millimeter spaces created in 4 months and a fairly comfortable appliance to wear. The compliance rate's pretty high with this appliance. Okay. Now there's some disadvantages with all appliances, right? The disadvantage of this appliance is that the most anterior tooth extrudes, and you can see it causes an open bite. So we're trying to figure out how to prevent the extrusion of that tooth. And we're working on a few things. Maybe trying to tie those bicuspids together by some, so that it's not all on the first bicuspid. But the bite does open, and you're going to have to close it with braces. So that's a little bit of a disadvantage, but it's certainly fixing the malocclusion. So then we put braces on. And I'm not going to go into tonight about how I do it with the braces, but we put the braces on probably for a year, and that corrects everything. We have to use some elastics to close that bite in the front. So about a year later, that's the patient looks like. Okay, so he looks pretty good. She looks pretty good. So she went from the left side, and I honestly think that was one of the easiest ways to correct that malocclusion. Okay, because remember, she started out, as you can see on the left-hand photo, she started with a real class 3 cuspid and class 3 molar. And look at the cuspid on the right-hand photo, you can see it's a class 1 cuspid. The upper cuspid is supposed to fit between the lower cuspid and the first bicuspid, and it's good, perfect. So I think the carrier really helped. And then, of course, you have to know what you're doing with the straight wire. So again, I charged $2,500 for the 5 months they were in the carrier. And then I charged $4,000 for the braces. So that's pretty well the fee I was charging before, $6,500. I'm charging $7,500 now because all my girls apparently wanted raises. They started talking about inflation and all this stuff one day, so I had to give them all a raise. Actually, I told them too that if the practice does well, you do well. And of course, the practice did very well last year, so they're entitled to a raise. I tell them, how do you expect I'm going to pay you unless the practice goes up in value? So they worked hard to get the practice up, and they benefited. Okay, so there's the other side. Pretty nice. I mean, that was really a pretty severe malocclusion. Look at that. And I look at that cuspid, how far forward it is on the upper. How it's just, no, it's back. Sorry, it's back, too far back. Upper cuspid is class 3. It's way back. And look at the molar way back. And then with that carrier for 5 months and the braces for 12 months, I mean, a pretty nice result. Actually, that's how the case started, but I didn't show you that part because it's very similar to the first case I showed you. So first, I mean, I didn't show you the first part of that case, but she actually had an anterior sagittal, but her growth pattern was more class 3-ish. So it was a more serious case than the first case I showed you. So there she is with power chain, closing all the spaces. There she is with the retainer. Unfortunately, I haven't got all the finals photos, but you can see that I got a photo of that side and it looks beautiful. Class 1 molar, class 1 cuspid, and that nice clear retainer that Bill makes. There's that nice clear retainer he makes, and the lingual bone retainer in the upper looks beautiful. And there's the lower, but I just don't have the picture of the other side yet. But you could see that when the braces were on, it was pretty good. And you can see the change in her profile. The interesting thing is, she started out with a kind of a prognathic profile or a straight profile, ended up kind of retrognathic a little bit, but she looks good. She looks good, and particularly the upper lip looks good. The upper lip looks nice and full. And I think that's really good. But I think that's an appliance you may want to think about too. Okay, so when you do the carrier, the mandible rotated down and back, and that helped correct the class 3. And again, there she was with her deficient maxilla, and there she is with a normal maxilla. So remember, the key is when you're a general dentist, treating class 3s, you're treating deficient maxillas. Prognathic mandibles are referrals. That's it. That's simple. Okay. As I told you, try to find an orthodontist that you can send your cases to. Have a good relationship with the orthodontist. You need them. You need all your specialists to work with. Now, I did write a book. I wrote a book on the early orthodontic treatment for children. And of course, there's a chapter in there on the motion appliance. And I think there's 19 cases in the book, 19 cases, start to finish, colored photos. I think for someone starting out in orthodontics or even doing it for a while, it's a pretty nice book. So you can phone Lee at Rondeau Seminars and get a copy of that book. And I don't even know what it costs anymore. I think 169 or something. So it's pretty reasonable. Now, the other thing that I got going in my office is, and in different places, we have mini residency. And I don't know if I mentioned this in the first session or not, but this is the best thing I got. This is a hands-on course in my office, work on my patients. I give my patients a discount because the dentists are going to work on them. So, and there's a dentist doing a consultation with a mother and a child. There's another dentist working with his assistant. And in my office, in most offices, they do it Thursday and Friday. So they'll meet on a Thursday night, and then we'll have a meeting and a 5-hour lecture and go over all your cases with you. And then dinner and diagnosis. We go over all your cases and have dinner. And she thought it was the best decision we ever made. And there's my boardroom. I always wanted a boardroom. So that's where I give the courses, in the boardroom. And also, and there you can see Dr. Raj working. There's Gina, my hygienist, been with me 25 years. And there's a couple of guys working. You even see me there giving some advice. And there's Peter. He's probably one of the most popular dentists that I've ever met that ever took my course. And there he is watching the hygienist work, his hygienist. And there he's watching again. And now he's working.
We're not, Brock, getting any sound from Peter.
Oh, really? Oh, that's too bad, because I know it's not very loud. So anyway, we'll praise him. That's too bad. So he was just basically saying how much he enjoyed and it was working on my computer, but it's not coming through on the other end. So that's too bad. But he just loved the mini residency. I think he started about 200 cases during the mini residency, and after he finished the mini residency, I think he had 200 active cases going. But he really studied hard, brought his hygienist, learned a lot, and he was one of the best people that ever took it. I mean, I've had other dentists start 200 or 300 cases too. And of course, Bill really likes them. And you know Peter well, I'm sure, because I'm sure he sends you a lot of business. So I have them in London. I have a mini residency in my office in London. I have it in Toronto with Dr. Raj. I've got it in Houston, Chicago, Vancouver, and Miami. So if you really want to learn ortho very quickly, hands-on, working on live patients, you can think about that mini residency and you talk to Lee about it. Okay. So the last case I want to show you is a severe case, the tandem appliance. And I've used this one. This was developed by a friend of mine, Leon Klempner, an orthodontist. He told Bill and I about this appliance probably 20 years ago, Bill. And for severe cases, to avoid surgery, this is the appliance we love. Okay. So severe class 3s, okay. Skeletal problem, which means they cannot bite end to end. When they bite, the mandible is forward into an anterior crossbite. They cannot bite end to end. Again, the best case is a retrognathic maxilla and a normal mandible. Okay. But this is the case that I love. This is the appliance I use. So in comes Zachary. He's 10 years old. Now, look at him. He looks like an overclosed denture patient, right? He's got a mid-face deficiency. Look at his thin upper lip. And he's overclosed vertically. So you're going to have to start recognizing vertical problems, and doing dentistry and look at teeth all the time. You don't pay attention as much as that. You do pay attention when you do an denture, but he's overclosed vertically, and look at his profile. Wow. That is not a good profile. I mean, it makes him look older, right? He looks older. He's only 10. So his mandible is quite far forward, but his maxilla is deficient. Now, if that maxilla was not deficient, I would not treat him. But when his maxilla is deficient, and the other thing you have to remember is when you're overclosed vertically, okay, like that, and you got a deep overbite, you need to increase the vertical, like I showed you in the first two cases. You need to increase the vertical dimension, and the mandible rotates down and back. That saves me on all my class 3s. So if I have a class 3 with a deep overbite, I say yes. If I have a class 3 with an open bite, I say refer. I want you to do the same thing. Okay? So wait and see what I do when I increase his vertical. Remember, the mandible will rotate down and back and partially correct the class 3. So there he is, deep overbite of 4 millimeters, 10 years old. So we got to fix that. I don't know how the poor guy chews. You know, like it's got to be hard on his jaw too to look like that. So there he is with a deep overbite of 4 millimeters, and you can clearly see the lower teeth are in front of the upper teeth, and the lower jaw is in front of the upper jaw. Okay, but that can be fixed easily. Okay, so he has difficulty chewing. He's been to an orthodontist who's been monitoring for 3 years, and that's okay. I mean, I'm just worried that if the orthodontist doesn't start treating him soon, he's going to need surgery. Okay, so you'll find some orthodontists are into early treatment, and some of them prefer to wait all the permanent teeth are out. I'm into early treatment. I want to use these appliances when cooperation is the best. I'd rather put a tandem appliance in a 10-year-old with a good attitude than try a 13 or 14-year-old boy and try to convince him to wear it. Big difference. Okay. This is just showing some of the records you're going to need if you do this, if you take a course. That's our record, you know, of all the summary of all the clinical findings. Then you have to do a perio exam. And of course, remember I told you before, you got to do a TMJ health questionnaire exam. So he's saying, okay, he's having occasional headaches, and most children, particularly females that are overclosed vertically, have headaches. And he's clenching and grinding his teeth. His jaws are tired after a big meal. Poor guy. I mean, if we don't fix that, that's not going to improve by itself. And there's the diagnosis. We have to have a page that we put all the diagnosis on. So we always divide it into functional, skeletal, dental. Okay. So functional problems, he doesn't have any. He doesn't have any functional. He has a little bit of a TMJ problem. I guess we could put that down. He doesn't have any habits though. Skeletal problem, he's got a retrognathic maxilla. He's got a bit of a prognathic mandible, but that's going to fix it. As soon as we open the vertical, it won't be prognathic anymore. He's overclosed vertically. He's got a class 3 molar relationship and cuspid. He's having an anterior crossbite. His overbite's 4 and his over just -4. Okay. So I think he went to 3 orthodontists, and I think 1 recommended headgear, which is good, because they were going to use a reverse face mask to pull the whole maxilla forward, which I agree with. I used to do those before I got the tandem appliance, and 2 suggested surgery. So he drove from Sarnia 60 miles to see me. And all we did, Bill made an appliance called the tandem, and we had to open his bite. And we couldn't open his bite enough with the buildups. So we had to use a special appliance with acrylic on the lower to open the bite. And see those 2 C clasps on the lower right on the bottom, and you'd put those clasps on the cuspid and the first bicuspid, and then put some composite in the middle to hold it in there, because you're going to have very good retention on this appliance when you wear elastics. You'll see what I mean. So the acrylic pads are about 5 millimeters high, which looks high to you, but now he's end to end. And remember, he had a -4 overjet. When I build him up 5 millimeters in the posterior, he's now end to end. Okay, and so the mandible now rotates down and back. We're changing him from a class 3 to a class 1 by increasing the vertical dimension. Unbelievable. And look at his face with just doing that appliance. I mean, he's got his lips apart. It would be nice if his lips were together, but he's kind of smiling. The girls must say, well, I want to smile at you. But he looks a lot better just already from the guy on the left when we open the vertical. And you'll see him improve all the way through treatment. So there's the appliance. That's the lower part of the tandem. It has Adams class on the first permanent molar. And then it looks like we've got the C class on the bicuspid and I guess the two bicuspids. And then we've got a little, you see at the side, we've got the to put the face bow into. What do we call that, Bill?
Those are actually headgear tubes, 045
headgear
tube.
tube. Okay, headgear tubes, because we're going to put a face bow in there, and you'll see just at night, and you'll see how it works. Okay, so there's the face bow in the buccal tubes. Okay, so he only wears the face bow at night. He doesn't wear the face bow during the day. Okay, and so it's a relatively, he's happier, because remember, when you're overclosed vertically, your muscles are sore because they're contracting all the time because they're the wrong resting length. So the minute you put that acrylic in there, you open up his vertical, his muscles relax, and he just feels so much better. So, I mean, it's really a great technique. If you see people overclose vertically, you got to build them up with something, either composite buildups or a splint or acrylic or something between the teeth to get the vertical correct. Okay, so there it is again with the buccal tubes and with the face bow fitting in there. Remember, you just put the face bow in at night, and there's the upper part. So sometimes you don't have to do a lot of expansion with class 3s but sometimes you do. But the upper part of the tandem always has a higher X screw. It has rests on the first bicuspids. So bands on the molars, rests on the first bicuspid with flowable composite. And you got a hook for elastics. You'll see in a minute. So there's the appliance. Put it in. The C class, remember the C class down there with composite buttons for retention. And remember, he was a class 3 -4 overjet, and now he's end to end, just with the buildups. And there's the appliance at work. So that's what we do. You've got that hook on the upper, and when you put the face bow in, you've now got elastics pulling everything forward. So this is mainly concerned about pulling the whole maxilla forward. So this is not going to move the mandible. It's going to move the maxilla forward. We've already rotated the mandible down and back with the buildups. And there it is. Now you're probably saying to yourself, who is going to wear this, right? So you have to have a highly motivated parent who tells them, look, you put this in at night, you go to sleep. Sleep in your back, you're fine. And this is going to mean you won't have surgery when you're 17. So do it. And it's a lot easier to motivate a 10-year-old than a 15-year-old, believe me. So get them early. They're in your practice. Find them and treat them. And don't be afraid of this appliance. I would say, Bill, probably this is the appliance that most people are afraid of, aren't they? Most of the dentists that take my course don't want to do this, but boy, when they do it, then they can hardly wait to start. Is that what you found too? Because they tell me that sometimes with the courses.
Well, it certainly looks like a mouthful to be putting in a young patient. And, in general, I think dentists are most afraid of class 3 cases to begin with. So
right.
This appliance, you're right, when they see the success of it, then they're quite happy. And plus, lately we've been doing the modification with we've got the daytime elastics, which we modified from the original Dr. Klempner design. So it makes the appliance that much more successful. And just as this patient shows, tremendous results.
Yeah. So there's his face to start with. There's his face now. What a difference. Wow. Look at the lips. Look at the difference in the lips. Look at the length of the face. Look at how he's a class 3 on the left. He's a class 1 on the right, just by opening the vertical. And there he's looking good. We corrected that. He's got a 1 millimeter overjet now. He was -4 to start with. He's gone from a -4 to a +1. I thought this one had some class 3 elastics on it, but I think the next one does, but I won't have time to show the next one. That's too bad. So anyway, then we put the straight wire on, line the teeth up. And that's look at the thin upper lip and look at the difference on the right. I mean, it doesn't even look like the same guy. And that's probably like 8 months later or less. Still got the same hairdo. If you look at the hair, it's the same hair. But he looks so much better. He's got a lip now, you know? So he's overclosed vertically. His lower face height increases, and he looks so fantastic. So we got new modification of this appliance now. Number one, we use elastics class 3 during the day. And Bill also has an anterior sagittal component at the anterior to move that forward if we want to. So there's been some change in this appliance. But I did want to show you the facial change we got with even the old design, which is pretty significant. Look at that face. It looks fantastic. I mean, you can't even equate the two. You can hardly believe. Imagine if his grandfather saw him on the left, and then a year later saw him on the right. He wouldn't recognize him. He wouldn't recognize him. So then we put the brace on and lined his teeth up. So the brace were on for a year. And there's the lingual bond retainer, remember, at the end. And this just shows the cephalometric film. So you do have to take cephs if you take the course. I have a 4-session course, which you can look online and see it. And just rondeauseminars.com, and you can see all the courses. And you can see details on what we do in each session. But look at the difference in the cephalometric film. The diagram on the left compared to the diagram on the right, it just even looked like the same person. But what a difference. This is why I like to go to the office every day. Well, we did charge them a little more for this. Charging $2,500 for the tandem and then $4,500 for the braces. And probably should have been a little higher for the tandem, less for the braces. Total of $7,000, the records are $500. Now, patients are very anxious to pay you whatever you want to fix these kids. Because if you don't do that, he's going for orthodontic surgery. And we don't want our children to have orthodontic surgery if we can prevent it. And without functional appliances, Bill, there'd be a lot of my patients heading for surgery. And you can't do braces on a patient like that. You have to use some sort of functional appliance, which again moves the whole maxilla forward. Look, there was a -4 overjet, and now there's a +1 overjet. That's a big movement. But remember, a lot of that was vertical. As soon as you increase the vertical, the mantle rotates down and back, and the rest was done with the tandem. Okay, I think I mean, that's pretty impressive. That's pretty impressive. Every time I see this case, I say, wow. I'm really happy I did him, and so is the mother, and so is he. So he's got a thin upper lip, he's got a full upper lip, and look at the mid-face deficiency. Now he's got a balanced face. I mean, same glasses, same hairdo. You'd think I could get a better smile out of him that, but I wanted him to show off his lip, so he didn't smile. Anyway, thank you. I guess I can't believe I finished at 1 minute past 8. This is unreal. This was supposed to take an hour, and it did. I practiced for 3 hours to get it down to exactly the time. No, I'm just kidding. So, Bill, thanks for your help. And,
well, Brock, before you sign off, though, we've got some questions from people that have been listening.
Oh, great.
So I'm hoping we've got time to address some of that. And you're right, you were extremely punctual. So, and these are some great results that you've shown. So we've got some great questions. The first one is, can you do arch expansion on a 30-year-old?
Absolutely. Absolutely. That midline suture doesn't close over till you die. There's cerebrospinal fluid going all through the skull all the time when you're alive, and when you're dead, there's no cerebrospinal fluid. So you have to have the sutures open for that. The only time it might be closed if you're in a serious car accident or serious trauma, then you might not be able to expand, but that's very rare. So you and I both know that you've been expanding arches for 30 years, and I've been expanding arches for 30 years. And if it didn't work, we wouldn't keep doing it. Now, the only thing I'll tell you is very rarely is the suture locked. And if you start expanding and it hurts or the teeth flare, you'll know it's locked. But that happens so rarely that I haven't seen it for years.
All right. And what can you tell us about retention protocols for children and adults and mid-treatment even sometimes?
It's too bad because I took some of the slides out of this presentation, but I had a retainer that was fixed, an upper fixed retainer, lower fixed retainer, like a lingual arch, and I had class 3 elastics on it. And he wore those for a couple of years after the treatment was over. Because remember, we did him when he was 10 with the tandem, and then we probably did him for 2 years till he's about 12 or 13. But boys grow to 17. So I had to put something in there to prevent the mandible from growing. So we make some fixed retainers with class 3 elastics from the lower to the upper to prevent that mandible from coming forward. And he wore that for a couple of years. I took that out of the presentation.
All right. And how about just arch development in general, not specifically related to class 3?
Well, I mean, I think they should maybe watch session 1 of this presentation because I showed class 1s and class 2s, and I showed all kinds of removable and fixed appliances to expand. But the upper Schwartz appliance is removable, but you've got other fixed appliances like the Hyrex. I showed you the Hyrex tonight. And also you've developed with Michael Williams, the Series 2000 appliance with the nickel titanium coil springs, which you don't even have to turn a screw. They just work by themselves. And you got about 1 millimeter a month expansion painlessly. And those are phenomenal. So anybody needs to call Bill if you don't know him and get him to send you a catalog of some of his removable appliances and fixed appliances, or watch the first session. We've done 2 webinars, Bill. This is our second one. The first webinar was class 1s and class 2s, and this one was in class 3s. Hope we didn't scare anybody away, because I honestly think that you should try to learn how to use these appliances, because you're going to prevent a lot of patients from having surgery, and you're going to get a lot of personal satisfaction in your practice.
Now, Brock, you mentioned class 1. The first webinar we did.
Yeah.
And maybe if Lee's listening, I'll ask Lee if you can. You did show Lee's the slide for Lee's contact for
Yes.
people to send a note to Lee, so she can actually send out the recording to anyone that would like it. Or if you
Right.
contact me, we'll make sure that you get it as well. Another one I have here. A concern about with the carrier class 3. Are you concerned about creating any TMJ issues using that appliance?
That's a really good question. It hasn't happened to me yet. And I think it's because the mandible rotates down and back, but the condyles must move out of the fossa because it doesn't seem to be distalizing the condyles. And I was really hesitant to use the appliance for a long time because I don't like class 3 elastics. But for some reason, I haven't had any patient yet say that they had TMJ problems from using it. But there's a force 1 elastic and a force 2 elastic. I showed the carrier class 2 elastic class motion appliance last time. You can use a force 2 elastic on a carrier 2, but you can't use anything but a force 1 elastic on the carrier 3, or you will cause TMJ problems. So you got to be careful. Anybody, I mean, what am I doing with my initial discussion of class 1, class 2s, and class 3s? I'm just showing what's possible. Okay. If you really want to learn about this, you've got to take a course. My course or someone at the course. You got to take a course on functional appliances. And you got to get some notes, and you got to look at some books, and you got to study this, and you got to learn about it, because I couldn't possibly tell you every detail tonight when I'm just trying to show you an overview of what's going on. I'm basically trying to get you interested in helping your patients and maybe recession proofing your practice, because right now there's a lot of competition out there. Every dentist is doing every dentist in the corner is doing fillings and root canals and extractions and everything else. And I think you need to set your practice up so you're doing something different. And if mothers are saying yes every time you show them a case that you can help their children, you're going to do really well. And those mothers are not going to leave your practice. They're going to stay with you. And so I just think not only is it very rewarding and very helpful to the kids, getting healthier and better looking. You can make some money doing this. And, but it's the personal satisfaction. I mean, Bill and I, as you can see, we both have gray hair, but we love doing this. We love helping dentists learn, because we know when we help a dentist learn, he's helping hundreds of patients his whole life. And that kind of keeps us going, doesn't it, Bill? We kind of like that.
Oh, absolutely. And, the feedback you get from successful cases in your office is tremendous. I know that, orthodontics in a general practice is very visual and helps to generate patient referrals coming into your office. People don't normally talk about where they got the root canal done, but people quite often talk about where they got their orthodontics or orthopedics done. So it's
Right.
tremendous that way. I do see a note here from Lee that says she will send out the first webinar to everyone that's here today. So you don't even have to ask for it. She'll just send that out to you. And another question is, how about extracting lower second molars to slow down mandibular growth?
I have not done that technique. I think if you wanted to distalize the teeth, that might be a good idea to take out the third molars. And I guess you could take out the second molars if you want to distalize the whole side back. It would make it easier. But I have not done that technique very often.
All right. And are there class 3 cases that you would avoid?
Yes, the class 3 case that I would avoid is where there's an open bite, skeletal or dental open bite. So if it's an open bite, for those who are just starting out, they don't know what a skeletal open bite is, but it's when you got a vertical grower, like a long lower face height. So those cases you want to avoid completely doing. You want to send those to an orthodontist, and usually the orthodontist will do jaw surgery to fix that case. But we can only do the cases mainly that have deep overbites and retrognathic maxillas, underdeveloped maxillas. That's where you're going to make your living. If you don't see deep overbites and you don't see retrognathic maxillas, don't do those cases.
Okay. What would be the ideal age for using a tandem appliance or anything else to correct a class 3?
So for tandem particularly, I think I like maybe 10 to 15. Because, well, you could do it from 8 to 15 too. I mean, I think when the patient's actively growing is a good time to do it, and you get good cooperation from them. Maybe sometimes 15-year-old boys are not that cooperative unless you tell them that you're either going for surgery or having to wear this, and you make up your mind. But remember, when they go for surgery at age 17 or 18, they have to also wear braces for 2 years. And what guy wants to wear braces at 17 or 18 years old when he should be in college or university or doing something, like he'd be done in high school? So we want to fix them before that. And we better to fix them before they go to high school too, obviously. But I think that would be an ideal age.
Okay. Now, this is not class 3 specific, but in the case of a posterior crossbite with a functional shift, would you use a fixed or a removable appliance for a 5-year-old child?
Well, that would probably fixed. Probably fixed. Yeah, because some 5-year-olds won't wear removable appliances, but some will. But then again, I always ask the mother, is your daughter a good cooperator? Does she do everything you tell her or nothing you tell her? So I was, of course, an ideal child. And of course, I would certainly wear a removable appliance if I was told to wear it, because if I didn't, I got the wooden spoon. My mother didn't fool around. What you're told, you get whacked with a wooden spoon. Now, today, that's called assault. You're not allowed to do it. But a lot of kids nowadays, some of the kids are well behaved and some aren't. It all depends on the parents. So when I'm choosing an appliance, I ask the mother what she thinks and show them both to them, and let the mother decide whether or not the child will be cooperative or not. Most boys get fixed. The girls, sometimes removable, sometimes fixed. Mother makes the decision.
All right. And my last one, would you use an anterior sagittal appliance if you had flared upper incisors?
No, absolutely not, because it'll flare more. So remember, the anterior sagittal is for minor cross bites, and it's when the upper incisors are vertical or lingual, and slight anterior cross bites. But we do a lot of them. You make me a lot of those appliances because I have a lot of children in my practice with anterior cross bites, and they come from other places, right? Remember, my practice is strictly referrals. I don't have a general practice. I don't do any general dentistry. So all my cases come for referrals. And it's amazing how many times children come to me where they've been somewhere else and the practitioner says, "You're too young, come back when all your permanent teeth are out." And the mother said, "I heard you do early treatment and here I am." I said, "Yes, we can fix that without surgery." I don't think I've ever had a child come in early that I've ever had to do surgery on. Because as you know, our functional appliances can change the bone, can change the teeth, can change the vertical. I mean, it just makes such a difference. So as you say, I mean, I love doing what I do. You love what you do. And I think a lot of the dentists that take the courses love what they're doing. So,
Oh, absolutely. I mean, I have the pleasure of talking to dentists pretty much all day, every day. And it's incredible the satisfaction that they get from really helping these young patients, young and old patients. And, as you say, it's life-changing for a lot of them. So I think that's what I've got. And just, one little piece of news, the Leafs are losing 1-0. And we're 5 minutes
wow.
into the second period.
Okay.
So.
Go Leafs, go.
Oh, we
Anyway,
hope.
thank everybody for attending. I appreciate your support. If I can be of any further assistance to you, there's some great courses coming up in Toronto in the fall. Bill and I always have a great course with Lee, and we'd certainly love to have you sign up, talk to Lee if you're interested, go online and look at all the courses and all the information. But the course involves orthopedics using these functional appliances, straight wire, and look at the TMJ and make sure that it's in good shape. And also a little bit about airways and snoring and sleep apnea, just a little bit, just to make you aware of the diagnosis of those cases too. Because children can have sleep apnea and children can have TMJ problems. And if you want to treat the child comprehensively, you got to know a little bit about all that. So our course is 8 days long, every 2 months, and the manuals, I think, are 250 pages each. So anyway, a lot of work, but a lot of rewards too. I'm teaching a course and there's hands-on, it's a hands-on course. We teach you how to do cephs and put on brackets and bend wires and do TMJ exams. And it's a hands-on course, adjust appliances. And so we get some good results, Bill. You've got a lot of dentists that have taken my course. They're doing good work.
Oh, absolutely. And, they do good work, and they've spent time and energy and become devoted in treating orthodontic patients. And they've had good leadership through that. So I know one of the things that's always been important is the support after taking a course, so that people don't feel like they're left alone. So, and I know you've got a great system for that. So, we hope to
One
see.
last thing. I'm starting virtual study clubs now, where dentists don't have to come live. They can send their cases to me and I'll go over them. We're starting our first virtual study club on Friday, and each dentist is allowed to bring 5 cases, and we meet every 3 months. And so I think that way they're going to get support afterwards if they need help. And I know, of course, they can call you anytime and get help, but that's something we're doing new because, people don't want to travel anymore. So they can sit in their own little living room and send me the 5 cases, and they'll see 5 cases of the other dentists. So that's something brand new. We're starting on Friday. So you're right. We're trying to follow up with support if they need it after the course is over.
Wonderful. Oh, we're always trying to move forward and improve things. So that's a great step.
Okay, Bill, thanks very much for moderating, and thanks for all you do for me and my dentist.
All right. Well, it's certainly our pleasure to be here tonight, or my pleasure to be here tonight and to help anyone. So thanks, Brock. And I hope Leafs turn it around tonight and everybody gets to enjoy the rest of the game.
Okay. Thanks for your support, everybody. Good night.
Thanks for being here. Bye-bye.